Thank you very much for inviting me again to this Congress here. In fact, it was 2017 when I delivered a review talk on PSMA, so many years ago. My talk today is on new possibilities in imaging neuroendocrine tumors. Just as a summary today, we have lots of guidelines listed here, starting over a decade now on somatostatin receptor diagnosis and therapy. Of course, most of you are aware of the vision of the NETA results. So in NETA 1 and also NETA 2, we have the data now that somatostatin receptor-based theragnostics prolong the life of the patients in terms of overall survival about 1 year when it is given in addition to somatostatin analogues. So the ideal patient treated with somatostatin receptor based therapy is a patient who is progressive on long-acting somatostatin analogues, who expresses large amounts of somatostatin receptors and has a high Karnofsky score. In the past years, we have working on how to improve those results, and one, or at least the best known possibility today is the combination with chemotherapy. So we give Captem, cabazitaxel, and temozolomide together with BRT during the cycles, and this may improve progression-free survival in patients who are progressive under PRT, and typically we give this combination schedule in patients as a challenge. And another possibility listed here is the application of new somatostatin receptor-based ligands, or also of new non-somatostatin receptor-based ligands. And this is my topic of today. So we will be talking, and I will give you a short overview on the cholecystokinin and gastrin receptor-based imaging. Typically, and the most important of these is the CCK2 receptor, which is expressed normally in the gastrointestinal tract and also in brain. And this receptor has been shown to be overexpressed by Professor Roy B. almost more than 30 years ago in medullary thyroid cancer, in small cell lung cancer, in certain kinds of gastroenteropancreatic cancers, and in some kinds of sarcomas. So in medullary thyroid cancer, we have the clinical situation that the cancer needs to be localized. And most of the medullary thyroid cancer lesions are usually identified nowadays by ultrasonography. And most patients do have already lymph node metastasis, and some, about 10%, may also show up with distant metastasis with advanced stage of the disease. Our most best known imaging agents is F18 labeled dopa for imaging lesions, and also there are some data that somatostatin receptor-based agonists and antagonists can identify MTC lesions, and thus can also be treated by lutetium or yttrium labeled somatostatin receptor analogues as shown here. But our results have shown that this methodology does not really work, so people have started to look into the CCK2 receptors. binding derivatives, and from here we start with the gastrin derivatives. So the story starts almost 30 years ago with the so-called Marburg compound, which was originally used by Gotthard and colleagues and Thomas Baer, who was also working here in London, and unfortunately missed several years ago. What we have with this compound, which is also called the MGO compound, minigastrin O compound, we have not only a high tumor uptake in MTC lesions, but we also have high uptake in kidneys, and therefore this substance is not useful for therapeutic purpose, and also has high bone marrow radiation. Okay, so over years people have then produced other agents looking or targeting the CCK2 receptor, and there was the COST compound, in which also Innsbruck was a center, a European multi-center study called TransCan, where the indium-labeled compound has been used to identify MTC lesions, and the paper only published recently has shown that the overall protection rate was about 80% over conventional imaging. My group now has changed a little bit the C-terminal part of the analog, and we have done a lot of in vitro studies to show an increased stability of the compound, and also a very high targeting capacity to MTC lesions in experimental animals, as shown here, and this compound can easily and stably be labeled with indium, gallium, or lutetium, as shown in these studies. Of course, also the group has compared the uptake to other agents as listed here and as known here, showing a superior tumor to kidney ratio, a superior tumor to stomach ratio in terms of less stomach ratio, and thus also a capacity more important for clinical imaging. I will not go too much in detail because of time. So for the production, we have now an automatic synthesis of a gallium-labeled DOTA MGS5 analog, minigastrin S5, small molecule 5 analog, it's called. We have product specification. We have very high uptake in experimental cells and cell lines, and also very high receptor affinity. Finally, the dosimetric studies in experimental animals have been the basis to apply this agent, MGS5, when I can repeat this, to patients. Over the recent years, several studies have been published. 5 years ago, this was the very first image that we published in the European Journal in the first patients with medullary thyroid cancer, where you can clearly see here additional small, tiny liver lesions as compared to somatostatin receptor scanning. So the scan uses gallium-68 labeled MGS5. Here you see the normal biodistribution next to the tiny medullary thyroid cancer lesion, high uptake in the stomach, because here we have a lot of CCK2 receptors, elimination via the kidneys in the bladder. Here you see multiple lesions in a patient with advanced medullary thyroid cancer with the compound. And here's a comparative study where you clearly see that the liver lesions in medullary thyroid cancer are much better distracted as compared again to the somatostatin receptor imaging agent. So this would mean that the substance, when labeled with lutetium, can be ideally also used for therapy. When processing the compound into the clinics, we recently have performed the first prospective study in patients with medullary thyroid cancer, but also in gastroenteropancreatic cancers. So after injection, the substance was well tolerated, and there were no real side effects except of a little flushing when the substance is rapidly injected. So slow injection is important of this gastrin analog. Here we have results. The substance depicts medullary thyroid cancer patients, but depicted also NET lesions and especially lung NET lesions, but not pancreatic lesions as by far. Here you see a typical patient with advanced medullary thyroid cancer. Also the same lesions were identified on the somatostatin receptor scan. And now this patient, of course, can be treated and could be brought to treatment. And now we are in the phase of treating these patients. So I have to say that after the initial compound, using the indium-labeled Marburg compound, which was not successful, the colleagues from Basel are performing the first prospective clinical trial using a similar analog, which is a little bit less stable than our analog. But anyway, you see here the first data presented by Dr. Rottenberger and our colleague Damian Wild from Basel, showing high tumor uptake again and also the capacity to treat these patients. So before we started treatment in Innsbruck, we sent this first particular patient to Basel for treatment. And here we have treatment results in a patient with medullary thyroid cancer. This is the Innsbruck image with the gallium analog, and this is the Basel post-therapy scan after several treatments. So in Basel, when overviewing the CCK2 receptor data, they are at the stage of escalating dosing up to 8 millicuries per patient, and the final results are not yet published, but toxicity is acceptable, especially for the stomach, as you have seen, because of the normal uptake is in the stomach. So also in Innsbruck, we are now commencing with the lutetium treatment with our MGS5 compound. And developing this again had a lot of preclinical studies regarding cellular uptake, regarding biodistribution, pharmacokinetics, dosimetry, preclinical pharmacokinetics in animals, and then translation into human. From all these studies, we can calculate that the standard dose which we used for Lutathera treatment of 7,400 megabecquerels in 4 cycles is clinically safe, also in terms of the stomach dose, which is the critical organ here. So we have prepared the master batches. We did all the quality control with the lutetium compound, the automatic synthesis, translation into clinics. Not only medullary thyroid cancer, but also small cell cancer, lung cancer expresses CCK2 receptors, and therefore together with the company Evergreen, we started a prospective clinical trial in small cell lung cancer. Small cell lung cancer is typically a very rapidly progressing disease with limited therapy options. Typically, patients receive chemo, receive checkpoint inhibitors, and then second-line therapies. So this would be an ideal tumor entity for treatment. Here's the first ever treated patient with small cell lung cancer with the lutetium-labeled somatostatin analog. So all this history here before receiving lutetium minigastrin therapy. The patient, unfortunately, was heavily progressed, and also progressed under the lutetium minigastrin therapy, but showed a very visible reduction of the congested neck veins and also reported improved quality of life. What you see here from this patient is the FDG PET scan with the lung lesions here, mediastinal lesions, lymph node metastasis, tumor recurrence in the minigastrin receptor scan before treatment, and here is the comparable somatostatin receptor scan, so very high uptake before treatment. Here we have the post-therapy whole body scan, again showing you the lutetium uptake after treatment and many, many lesions. The dosimetry in this patient was very high, was very good, with tumor lesions up to 28 gigs per gigabecquerel, which is really, as you know, a very high tumor dose. And fortunately, also the tumor to stomach dose was very good, as well as the tumor to kidney dose. Here is the prospective study we are doing with the gallium analog. Centers are in Innsbruck, New York, Milano, Munich, and New Delhi for recruitment of the patients together under a protocol sponsored by Evergreen, which was recently bought by Lantheus. And this shows the importance of this new development. And we hope that I can get back to you soon with the treatment results. Thank you very much.